4, 3.
Good afternoon, everyone. I am Beatriz Gal, full professor of physiology at the Universidad Europea de Madrid and PhD in neuroscience from the Universidad de Alicante. I would like to thank and welcome all the attendees from everywhere joining us this afternoon in this presentation of the International Online Master in Sleep Medicine, where we will also have a masterclass conducted by Dr. García Borreguero. I'm very grateful to the Sleep Research Institute for offering me the opportunity for being the academic director of this master. I'm delighted to present and moderate this meeting because a new exciting project is starting with it. The Sleep Research Institute, in collaboration with the Universidad Europea de Madrid, has developed this master, which is going to be taught fully online, in order to make it compatible with the professional life and activities of the students. This international master in sleep medicine has the best clinical professionals, academics, and researchers. The Sleep Research Institute is a reference in this field that has been working for 20 years on it, and the Universidad Europea de Madrid counts with an extensive academic international experience. I'm sure both institutions are going a perfect team. I would like to introduce you now the Universidad Europea de Madrid so that you can know its characteristics. So let's go to play a video.
My name is Cassandra Thomason. I am studying international relations here in Madrid at Universidad Europea.
My name is Yutong Han, and I'm studying sports science now.
I'm Jorge Ri. I'm studying computer science and business administration here in Universidad Europea.
My name is Anna, and I'm studying fundamentals of architecture, 85% in English.
My name is Lucas Berndl. I study the MBA Sports Management at the Real Madrid Graduate School.
I chose Universidad Europea because it's known for being very international.
They had a program that was very specific for what I wanted.
Because of its project-based educational system.
And here we are all the time doing projects, doing practical things, and not just the theory.
My integration to the school was really good because the staff of the university is very helpful. They help whenever they can.
Most of the professors and the students are also very friendly and kind.
All the professors are willing to help you, and if you have any doubts, they assist you.
We have small classes, which gives you a tighter bond with them.
They are like a little family that you can have in here.
Madrid is a very international city, but also still very, very traditional.
It's a very warm environment here in Spain. People are very friendly.
I'm relaxed here.
Madrid is just a great city.
3 words for Universidad Europea is full of energy, technology, and awesome.
Friendly, professional, and active.
It's innovative, it's creative, and it's really inclusive.
Excellence, practice, and professionalism.
International, very innovative, and trustworthy.
The school provides a unique opportunity to study in such a professional atmosphere and so close to the actual practice.
It's an amazing place to be, an amazing place to study.
It's very easy to be here, to enjoy the studies, to enjoy life, to make friends, and to network as well.
I would recommend Universidad Europea specifically to international students because they give us the opportunities and the tools we need to grow.
So that was from the students' point of view. Let's know a bit more about the Universidad Europea, its structure and students and schools and so on. So let's play a presentation now. The Universidad Europea has 4 campuses located 2 in Madrid, 1 in Valencia, another one in Canary Island. and we offer training cycles, degrees, and postgraduates and we are organized in 4 different schools: biomedical, architecture, social sciences, and sports science. And especially for the biomedical and health sciences students, we have as well 2 university dental clinics. We have more than 18,000 students, of which more than 6,000, are international students from everywhere. And we have our academic excellence is accredited by 4 quality seals different, and our ranking of employment is very good, being almost 90% 1 year after completing their graduate studies. We are very aware of the social impact that we can have, so that we work on international different collaboration projects, and we treat more than 30,000 patients in difficult conditions every year. Our educational model, I think, defines our university and is quite unique, and I'd like to explain a bit more of it. We have experiential learning in simulated environments that aims to place the student in a position closer to the professional world. Especially in the biomedicine and health studies school, we have a simulated hospital, a simulated pharmacy, and a simulated intensive care unit. Besides, our students can practice different procedures in the university health clinics, and we also count with a psychosocial care center. Our students learned with other professionals, working as a team, adapted to a real world, and developing critical thinking as a competence, so that they can make a decision based on data analysis. So we create citizens with global citizens with responsibility, assets, and with the ability to respond in a world fully of opportunities. And we achieve all this through a comprehensive curriculum that has an approach which is more holistic than in traditional models. Let's focus now in our school, which is the School of Biomedical Sciences and Health. In that school we have a different degree program, like biotechnology, nursing, medicine, nutrition, dentistry, and psychology. All these programs are offered to 5,000 students that follow an academic model that is based on our educational model. So we believe in educating our students so that they become citizens with social responsibility, with a scientific, clinical foundation knowledge, and with the ability to work with other professionals. Thank you very much for listening to me about my university, which I'm very proud of it. And let's now be back to the Master in Sleep Medicine. And now I would like to tell the audience why the sleep medicine is increasing, why it's important, and why it's increasing its importance. Sleep medicine has gone over the last decades from being an area with a certain medical and scientific interest to becoming a mature discipline with a solid and widely accepted scientific foundations. Furthermore, given the high prevalence of sleep disorders among the population, their knowledge and mastery is of great interest in order to complement the training of certain professionals as physicians, nurses, psychologists, dentists, biologists. Given the variety of pathology that we can find under this heading, the professional dedicated to sleep medicine must have a multidisciplinary vision. Therefore, the fact of developing a complete master on sleep, which allows a broad and practical knowledge of this disorder, is a challenge that we have opted for. From the point of view of medicine, there are multiple specialties that may involve in sleep disorders, from neurology, pneumology, neurophysiology, dentistry, psychiatry, endocrinology, and of course, family medicine and pediatrics. Within the training programs in different medical specialties, we found that none is exclusively dedicated to sleep medicine or somnology, which is why professionals who are dedicated to this type of pathology require complementary training to obtain such a multidisciplinary vision and acquire the skills necessary for it. Hence, the interest of our master. Finally, in some European countries and the USA, professional training exams have been available for years. Since 2012, the European Sleep Research Society, ESRS, offers a degree called Certificate in Somnology that is not only recognized for all the European countries, but is also one of the most prestigious sleep degrees in the world. This certification is accessible to people from all over the world and includes an exam that is held annually. The main purpose of this master is to offer a solid and up-to-date theoretical practical knowledge about sleep medicine, training the student to practice this medical discipline. In addition, this master will serve as preparation to the students who wish or need it, that can take to prepare them to take the exam offered by the ESRS or for other professional exams such as Spanish exam. Before I give the floor to our speakers, I would like to tell the audience about the Sleep Research Institute. The institute is under the direction of Dr. García Borreguero, who is my right, sorry, and is a reference center in the field of sleep disorders in Europe. The institution has published several papers in outstanding journals of the field and evaluates an average of 1,200 patients each year. Dr. García Borreguero coordinates a multidisciplinary team of specialists in neurology, neurophysiology, pneumology, psychiatry, orthodontics, and cognitive behavioral psychology at the service of sleep medicine. The story of the Sleep Research Institute started in the Jiménez Díaz Foundation Hospital in Madrid, where Dr. García Borreguero created and developed the sleep unit of this hospital between 1995 and 2005. The sleep unit became the main center of integrated diagnosis and treatment of sleep disorder in Spain at that time. In the Sleep Research Institute, patients with the most diverse sleep pathologies are studied and treated, aware of the importance of sleep, both for physical health and for facing family, work, and social life. The center has all the human and instrumental resources for the evaluation and correct management of these pathologies. Along with the clinical duties, the Sleep Research Institute carries out important research work, which in turn has an impact on the most effective treatment methods. The result of this research work is the production of studies that are published in the main national and international scientific journals of reference for sleep specialists. All this makes the Sleep Research Institute a well-known reference as a cutting-edge center in the treatment and research of sleep disorders. The Sleep Research Institute has been accredited by Spanish Committee for Accreditation in Sleep Medicine with the category of Multidisciplinary Center in Sleep Medicine and has the endorsement of 5 medical societies. Dr. García Borreguero is accredited as a specialist in sleep medicine by the European Sleep Research Society and the American Board of Sleep Medicine. In recent years, the Sleep Institute has begun an international expansion by creating 2 similar clinics in Santiago de Chile and in Panama. Let us now introduce Dr. García Malo, and to my left, and Cano Pumarega, to my right, who work as the Sleep Research Institute and are the coordinators of the master. They are going to explain us in more detail and depth the approach of the master, what are its learning outcomes, how it's the syllabus organized, the structure and methodology, as well as the professors and academics who are taking part on it. Before I leave the floor to Dr. García Malo, I would like to introduce her to the audience. Dr. García Malo completed her medical studies at the University of Alcalá de Henares in 2012 and specialized in neurology at the Puerta de Hierro Majadahonda University Hospital in 2017. She is currently part of a team at the Sleep Research Institute as a neurologist specialized in sleep disorders, developing clinical and research activities. She is a member of the Spanish Society of Neurology and the Spanish Sleep Society, and obtained the title of Specialist in Sleep Medicine issued by the Spanish Committee for Accreditation in Sleep Medicine in 2018. She is also a member of the European Sleep Research Society and the International Restless Legs Syndrome Study Group. Dr. García Malo has strong experience in treating headaches, dementias, epilepsy, and neuromuscular disease. She has an extensive interest and experience in transcranial ultrasound of the brain parenchyma. In 2019, Dr. García Malo studied the master's degree in clinical management, medical and assistant management in the Cardenal Herrera University. She is currently performing her PhD studies at the Universidad Autónoma de Madrid on the usefulness of transcranial ultrasound in patients with restless legs syndrome. She was awarded for the best scientific communication at the 2019 annual meeting of the Spanish Sleep Society for the work entitled Usefulness of Transcranial Ultrasound to assess brain iron and predict the response to intravenous iron in restless legs syndrome. She earned the Wayne Henning Young Investigator Award for the work entitled Evaluation of Brain Iron Deposits in Restless Legs Syndrome, the promising role of transcranial sonography, presented at the World Sleep Congress held in Vancouver in 2019. She authored several publications in national and international scientific journals, and she has participated in several clinical trials. Dr. García Malo, we are looking all forward to listening to you. Thank you very much.
Well, thank you, Beatriz, for your introduction. Today I'm going to tell you about what's the master's degree in sleep medicine about, the objectives and goals, and I'm going to present the table of contents. Well, what's the master about? We are offering a complete master in sleep medicine. We are doing it 100% online, and we offered it in 2 different languages, both Spanish and English. It is very important to mention that as it's offered online, everyone around the world can go for it. Thank you. What's the importance of this master? I think that, as Beatriz has mentioned previously, sleep disorders are really prevalent among different populations. So physicians that dedicate themselves to sleep medicine are absolutely necessary. And here I would like to tell a little about my own experience when I started treating sleep patients, because as Beatriz says, I'm a neurologist, and when I started visiting sleep patients, I realized that I had to know something about other specialties that I didn't know at that moment. So that you really have to put on a pulmonologist's shoes sometimes, and this is an absolutely multidisciplinary kind of medicine. So I think that having different points of view of a same disorder really makes us better professionals, and I'm still learning a lot about pulmonologists or psychiatrists that work with us every day. And this is where all the idea of developing this kind of master started a few years ago, and now it is coming true. So now I'm going to tell you about the objectives and goals that we have with this master. We want to go deeper in sleep medicine. We want to give you complete formation about what's sleep medicine, and we want to do it in a very multidisciplinary way. As Irene Cano is going to present later, you have to know that there's a great variety among our professors, and this really makes the master very rich. We want to offer a complete and updated vision about sleep disorders, and for that we would go from physiology, what's normal sleep, to sleep disorders. We're going to learn how to evaluate the patient, what's important to ask to the relatives, and we're going to study how useful complementary tests could be for the proper evaluation of our patients. But we also want it to be very practical, so for that we have included into our program a lot of practical cases, and we're going to do a lot of discussions on that so that the student can really learn how to manage into their daily practice. Who's this master for? Well, I think that every specialist that has something to do with sleep medicine could be really interested in that in order to increase their current knowledge on sleep medicine. And I think that this involves neurologists, pulmonologists, psychiatrists, psychologists, odontologists, otorhinolaryngologists, pediatrician, and of course, primary care. There's a global need for developing multidisciplinary units that dedicate to sleep disorders. And a lot of professionals that are related with sleep medicine need to complete their current formation. And some of them would like to access to an official title, as Beatriz mentioned previously. So that we want the master to be a kind of preparation for those who want to go for the European Sleep Research Society expertise in sleep medicine or any kind of official title related with sleep medicine. So for that, we are going to give the student a reliable and updated material that could be useful for that. We want to complete the formation for those specialists that are in touch with sleep medicine. And we also would like to go deep into the importance of a multidisciplinary approach, as you will see with the presentation that Dr. García Borreguero is going to give us. We want also to offer a very practical vision to the student, so that the master will be completed with an investigational project or a master's thesis. Irene is going to tell us more about that. And we would like to promote the publication of those of greater interest. And now I'm going to move on to the table of contents of our master. You can see Module 1 will be about normal sleep. We're going from physiological basis of sleep at Chapter 1, normal sleep regulation mechanism, chronobiology, circadian rhythms, biological function of sleep, sleep and age, sleep disorder prevention. Chapter 2 will be about the assessment of sleep disorders with the classification of sleep disorders, the clinical interview and the clinical examination. Chapter 3 is about complementary tests. Here we're going to talk a lot about polysomnography, that, as you know, is one of the most useful complementary tests that we can use for the proper evaluation of the patient. But we're also going to see respiratory polysomnography, actigraphy, among others. And then if we continue with the Module 2, here we're going to see every sleep disorder. We have tried to make it very easy to follow by the students. So we're going to keep on with classification, pathophysiology, diagnosis, and treatment of all disorders. We're going to begin with Chapter 4, insomnia, which is one of the most prevalent sleep disorders, classification, pathophysiology, clinical features and diagnosis, comorbidities, non-pharmacological treatments, and here we find cognitive behavioral therapy, and of course pharmacological treatments. Chapter 5 will be about sleep-related breathing disorders. Here we are going to talk a lot about the sleep apnea, obstructed and central. We're going to give information about devices for the treatment of respiratory disorders. Chapter 6 will be about hypersomnias of central origin. We have narcolepsy and also hypersomnia, idiopathic hypersomnia, Klein-Levin syndrome, etc. Chapter 7 will be about circadian rhythms disorder. Here we have delayed sleep-wake phase disorder, advanced sleep-wake phase disorder, but also free running, jet lag, shift work, etc. Chapter A is about sleep behavior disorders. Here we have parasomnia, both REM and non-REM, but also nocturnal epilepsy. Chapter 9 is about sleep-related movement disorders, of course, restless leg syndrome, another very, very prevalent disorder, periodic leg movement disorder, bruxism, leg cramps, etc. Chapter 10 is about sleep disorders among different populations, such as sleep in childhood, in adolescents, sleep in women, sleep in elders, also in degenerative diseases, and also in addictions. And chapter 11, last but not least, we have miscellaneous. We're going to talk about sleep genetics, legal medicine and sleep, ontogenesis and sleep and nutrition. That's all the table of contents. As you have seen, we're going to take care about all sleep medicine. And I think it's organized in a very didactic way so that the student can easily follow up the contents. And to finish, I want to thank the professors, the Universidad Europea, the collaborators, Diego, Irene, and our staff. And that's all. Thank you.
Thank you very much, Dr. García Malo, for your presentation. I think it's a very attractive program, so I think the students are listening to us think the same way as I do. I'm going now to introduce Dr. Cano Pumarega, and before I leave her the floor, Dr. Cano Pumarega completed her medical studies at the Miguel Hernández University of Elche in 2004. She got an expert course in sleep medicine awarded by Spanish Committee for Accreditation in Sleep Medicine in 2014, and in 2017 she earned her PhD in medicine by the Universidad Europea de Madrid with a qualification of outstanding cum laude. After completing her PhD, she continued her training and earned the master degree in advances in the diagnosis and treatment of sleep disorders from the Universidad Católica de Murcia in 2018, and a master degree in clinical management of healthcare units from the Menéndez Pelayo International University in 2019. She has a long teaching career since she has been a professor of Universidad Europea de Madrid in the degree of medicine from between 2012 and 2017. And she is a professor of 6 masters in sleep medicine from 2016 until now. And she has been the director of 5 courses on sleep disorders between 2015 and 2019. Her clinical activity has been carried out at the Getafe University Hospital since 2005 and until 2009, specializing in pneumology. She made a rotation, 2 different rotations in the USA in 2009, one in the new medical center, Tufts Medical Center in Boston, another one in the hospital in England, Sinai Hospital in Massachusetts. And from 2009 to 2019, she earns a pneumology permanent position at the University Hospital in Getafe. She is an expert in sleep medicine at the Sleep Research Institute from 2013 to present. Since 2019, she is a coordinator of the high complexity multidisciplinary sleep unit at the Ramón y Cajal University Hospital. She has authored more than 40 scientific papers in national and international journals and numerous books chapters. She has as well authored more than 100 communications to national and international congresses in the area of sleep disorders. She actively participates in national multi-center research works and in international clinical trials in the field of sleep medicine. She is a collaborating researcher in 16 research projects, being her main lines of research sleep breathing disorders and restless leg syndrome. She has obtained 7 prizes as first author for her work presented in different scientific societies and health institutions. Irene, we listen to you. Thank you very much.
Good afternoon, and thank you very much, Beatriz, for your presentation. First of all, I would like to talk about the curricular profile of our teaching staff. This master offers as a differential value its professional prestige by counting on international experts from Europe and North America in the respective fields, very active in research, and most of them being also authors of the European book from the European Sleep Research Society. In addition to the invited professors, doctors from the Sleep Research Institute from Spain, Chile, and Panama will also participate in the master. So there are professors from all possible fields involved in sleep medicine, which is very enriching, as Celia said before, as you will be able to see in this masterclass taught by Dr. Garcia Borreguero. As Celia also said, the fact of working daily side by side with different specialists has made us all grow very much in the field of sleep medicine, and that's exactly what we would like to convey to our future students during their training period with us. I will now briefly introduce our teaching staff. First of all, I would talk about Joaquin Duran. He's a pneumologist, doctor of medicine, and professor of medicine in the Basque Country. He's president of the Spanish Federation of Sleep Medicine and head of the research department of the BioAraba Research Institute in Vitoria. He stands out internationally in the field of respiratory sleep disorders. Second, we have Carlos Egea. He's a pneumologist, head of the functionally sleep unit at the Álava Hospital and director of quality and innovation of the Spanish Society of Pneumology. He also stands out internationally in the field of sleep-related breathing disorders. We also have Colin Spee. He's professor of sleep medicine at Oxford University, director of the Experimental and Clinical Sleep Medicine Research Program, and clinical director of the Institute Circadian and Sleep Neurosciences. He is also professor emeritus at the University of Glasgow, and he's internationally known for his work on insomnia and its treatment using cognitive behavioral therapies. We also have Alex Iranzo. He is a specialist in neurology and doctor of medicine. He's currently the president of the Spanish Sleep Society, coordinator of the multidisciplinary sleep unit at the Hospital Clinic of Barcelona, and he has done extensive work in research of parasomnias. Next, we also have Gert-Jan Lammers. He's a specialist in neurology and director of the Sleep-Wake Science Center associated to Leiden University. His main area of interest is narcolepsy and other hypersomnias. He's co-founder of the European Narcolepsy Network, being currently its president. We also have with us Luis de Lecea. He's doctor in molecular biology from the University of Barcelona. He has developed an extensive research career at the Scripps Research Institute, and he's currently professor at the Stanford University in California. Among his achievements is the discovery of hypocretin. We also have with us Teófilo Lee Chong. He is a pneumologist and professor of medicine at the University of Denver. He is member of the editorial board and reviewer of several medical journals, and he was awarded with the American Academy of Sleep Medicine Excellence in Education Award. We also have in our staff Federica Provini. She is doctor and professor at the University in Bologna. She has developed an extensive research career in the characterization of movement disorders during sleep and neurodegenerative disease with multiple publications in this field. We also have Dennis Rosen. He's a pediatric pneumologist, a doctor of medicine, and a sleep medicine specialist at Boston Children's Hospital, and he's also professor at Harvard Medical School. We also have Deborah Skin. She's a doctor and professor of neuroendocrinology at the University of Surrey, UK, and she's currently the head of the chronobiology department. She has extensive experience in circadian rhythm research and chronobiology. Next, we have Lourdes del Rosso. She's a sleep physician at Seattle Children's Hospital. She has a master's degree in medical education at the University of Pennsylvania, and she's associate professor in the Department of Pediatrics at the University of Washington. She is dedicated entirely to the field of pediatric sleep medicine in areas of education, clinical care, and research. We also have with us Marco Zucconi. He is a specialist in neurology and professor of neurophysiology at the Vita Salute San Raffaele University School of Neurology in Milan. He is a co-founder of the International Rest-Leg Syndrome Study Group, and in the past he has held the positions as president and secretary of this European Rest-Leg Syndrome Study Group. Next, we have Christian Bachelet. He's a specialist in otorhinolaryngology. He deepened his studies in sleep medicine in Colombia, sleep respiratory disorders in Mexico, and maxillofacial surgery in Colombia. We also have Sarah Boyce. She's a specialist in psychiatry and cardiovascular surgery, currently a doctoral candidate in medicine, and her main areas of interest are psychosis and psychopharmacology. And we also have Thomas Bernhardt. He is a specialist in dentistry, subspecialized in temporomandibular disorders and orofacial pain, and he completed his fellowship in sleep medicine. He's currently the president of the Chilean Society of Sleep Medicine and the director of the specialization program in temporomandibular disorders and orofacial pain at the Universidad de la Frontera. Also have in our staff Iván Eguzquiza. He has a degree in psychology and master's degree in cognitive behavioral therapy for the Bertrand Russell Center, and he has extensive experience with cognitive stimulation programs, as you will see. Next, we have Carles Gatch. He's a specialist in neurology and expert in sleep medicine at the Hospital Clinic of Barcelona. He's currently the coordinator of the study group of wakefulness and sleep disorders of the Neurology Spanish Society, and he has extensive research experience in the area of movement disorders during sleep and in parasomnias. We also have Sergio Hernandez. He's a technician in polysomnography since 2009 at the Sleep Research Institute, and he's an expert in the sleep laboratory techniques degree. He participates in multiple research studies on insomnia and restlessness. We have also Juan Antonio Madrid. He has a biology graduate and extraordinary award of doctorate in physiology from the University of Granada. He's a specialist in nutrition and in chronobiology from the Université Pierre-Marie Curie in Paris, and he stands out in his role in chronobiology research. We also have Veronica Martinez. She's a specialist in gynecology and obstetrics, and she has a master's degree in human reproduction. We also have in our staff Milagros Merino. She's a specialist in neurophysiology. She's doctor of medicine and she's expert in sleep medicine. She's currently the coordinator of the neurological sleep disorder unit at La Paz University Hospital, and she's the elected president of the Spanish Sleep Society. She has extensive experience in sleep disorders in children. We also have with us Nestor Montes de Oca. He is a specialist in oral and maxillofacial surgery, graduated in orthodontic surgery, and Doctor of Medicine. He is currently the co-director of the Department of Oral and Maxillofacial Surgery at the Hospital La Luz in Madrid, and the chief of the Oral and Maxillofacial Surgery Service on the Anderson Cancer Center in Madrid. We also have with us Isabella Novo. She is a specialist in neurology and doctoral candidate in medicine. She completed her training at Mount Sinai Movement Disorders Unit in New York, and she is currently pursuing a master's degree in movement disorders. We also have in our staff Javier Puertas. He is a specialist in clinical neurophysiology, doctor of medicine, and he did a mini fellowship of the American Academy of Sleep Medicine at Mayo Clinic in Minnesota. He's an associate professor at the University of Valencia, and he's currently the coordinator of the neurophysiology service and the sleep disorder unit at Universidad Universitario de la Ribera in Valencia. And we also have Maria Redondo. She has a degree and doctorate in dentistry, and she's a specialist in prosthesis implants. She has done a course of endodontics and university certificate of diagnosis and treatment on temporomandibular disorders and orofacial pain. And finally, we also have with us Pilar Riobo. She is an endocrinology and nutrition specialist and doctor of medicine. She is the head of the endocrinology and nutrition unit of the Hospital Jiménez Díaz. We also have Sofía Romero. She is a specialist in pneumology and doctoral candidate in medicine. She extended her studies in sleep disorders in New York at several centers. And finally, we have Christian Sanchez. He is a specialist in neurophysiology and doctor of medicine, and he's part of the working group of movement and behavior disorders during sleep of the Spanish Sleep Society. So, as I told before, we have an outstanding staff with all the fields that have to do with the sleep medicine. Next, I will briefly talk about the structure and methodology of the master. As Celia mentioned before, this is a very complete 100% online sleep medicine master degree endorsed by the Sleep Research Institute and the European University of Madrid, lasting 11 months from March 2021 to January 2022. The students will have access to the virtual campus of the European University, where all the videos, material, and webinars will be posted. It's accredited with 60 ECTS credits. That the ECTS credits are the European Credit System Transfer system used by the European universities, of which 48 of these credits correspond to the syllabus and the theoretical classes. 6 credits correspond to the master thesis, the final project that I will talk about. And finally, the remaining 6 credits correspond to the internship that will be held also online in the form of clinical cases, as Celia said before. The official languages of the master are Spanish and English according to the student's preference. The classes will be taught in Spanish and English, and in the form of videos with slides from each professor, and all the students will also have at his disposal the theoretical content of the official book of the European Sleep Research Society. That is written in English, as is the language in which this exam will be taken. This exam has a theoretical part and a practical part. The theoretical part refers to an exam that is generally held once a year, and our master in sleep medicine offers the necessary training to successfully pass this exam. However, a practical program must be completed in order to gain access to the European degree. This means that the candidates must prove that she or he has the necessary experience in a recognized sleep unit. So therefore, from the Sleep Research Institute, we offer the possibility to the students of the master who wish to do this practical part in any of our centers in Madrid, Chile, or Panama for an additional cost, and it could be online or in person. In addition, one of the main added values of our master degree is the monthly webinars broadcast live, led by an expert. We taught in English, and these webinars will be given by our guest professor that I'll talk about before, and the students will have the opportunity not only to listen them, also to interact with them. And if necessary, students will be able to request online tutoring sessions with the coordinator of the master. And finally, I will talk briefly about the final project. The aim of this master final project is to create a project report of a study with a student that develops the skills and knowledge acquired during our course. The students can present a research project, reviewing previous literature of the subject, or conducting a comprehensive review of the current state of an issue regarding sleep medicine. To do so, students will have the support and the supervision of the director and the coordinators of the master. And as Celia mentioned before, the Sleep Research Institute will promote and encourage the publication of the final project in scientific journals of the works with the highest quality. And that's all. Thank you very much.
Thank you very much, Irene. Well, finally, I have the pleasure to introduce Dr. García Borreguero, who is going to conduct the masterclass of this presentation. But first, let's know a little bit about him. So, Dr. García Borreguero, Diego García Borreguero, studied medicine at the University of Navarra and specialized in neurology and psychiatry at the Max Planck Institute in Munich, Germany, obtaining a PhD in neuropharmacology from the Ludwig University Maximilian of Munich. Between 1990 and 1995, he worked in the USA, where he specialized in sleep medicine at the National Institute of Health and at Georgetown University Hospital in Washington. In 1995, back in Spain, he created the sleep unit of the Jiménez Díaz Foundation Hospital, making it a reference in Spain at that time. He remained there as director until 2005, where he founded the Sleep Institute of Medicine in Madrid, where he is the medical director. He has been secretary of the the European Sleep Research Society, and president of the Spanish Sleep Society. He is currently a member of ESRS Examination Committee and chairs the ESRS Clinical Guidelines Subcommittee, as well as the Scientific Committee of the Spanish Sleep Society. He is certified in sleep medicine both in the USA and in Europe. He is one of the leading international opinion leaders in sleep neurology and has authored more than 150 scientific publications in journals such as Lancet, Neurology, New England Journal of Medicine, British Medical Journal, Scientific American, Neurology, Neuroscientist, Sleep Medicine of Movement Disorders. He actively participates as a speaker at the main international congresses and regularly speaks courses and conferences in Europe, USA, and Asia. I have the pleasure of giving the floor to Dr. García Borreguero, with a presentation entitled Regarding a Case of Insomnia, the Need for a Multidisciplinary Approach. Thank you very much.
Well, thank you very much, Beatriz, for the nice introduction. So, what I'm going to do for the next half an hour or an hour will be, by means of a case, trying to show you how the different perspectives that you can take in sleep medicine might change the final picture. I titled the case On a Case of Insomnia, Why We Need a Multidisciplinary Approach. I could also have titled it On Insomnia, the Different Phases of Sleep Medicine. And the point that I will try to make here is that depending on how you view it, you will see one reality or the other one. Okay, let's go to the case and we will discuss it as I provide more and more information. So, normally in every medical approach, there are two different views. First, the clinical point of view, which is this is the information that you gather when you talk to the patient. The patient tells you his or her version of things. Maybe you get also the point of view of the relatives, and it gives you a specific picture or a specific, let's say, suspicious diagnosis. You start thinking on possibility A or maybe possibility A and possibility B. There is a different way of looking at it, and this is the instrumental, the objective testing, and this will provide in sleep medicine a very different point of view in certain cases. So let's go to the information that we have. This is about a 72-year-old woman. She came a few months ago to our outpatients clinic, and she had been suffering, so her complaint was insomnia since the age of 23. Initially it was very mild, but over the years, there was a progressive worsening in severity over the years since the age of 23. She's now 72. For over 50 years, there had been a progressive worsening of the disorder. Its initial onset coincided more or less with the first pregnancies. She had 6 children, quite a lot, and 2 abortions, 8 pregnancies. But she dates the beginning of the symptoms with the first pregnancy. Over the years, over these 50 years, she has been treated for long with lorazepam, a benzodiazepine. I just wrote on the slide, just for those of you that don't know it, in the United States, and maybe in some other countries, it's called Ativan. Her symptoms have been, well, as I said, worsening over the years, but they worsened particularly over the last 2 years. The last 2 years have been terrible. There are a number of precipitating factors. One of them is that she had a bilateral arthrosis in the knees that underwent orthopedic surgery on both knees. In addition, her husband died a year ago on a stroke. And in addition, she has been suffering, like every one of us, like you and me, a lockdown over the last year, is worried about the COVID crisis, is really fed up of the whole thing, like you and me. But being 72 and being in that condition makes things worse. So she has been suffering particularly much out of that. Her past medical history: she suffers from hyperglycemia, she suffers from hypercholesterolemia, cholelithiasis. Her gallbladder was removed 3 years ago. She suffers from a dry eye syndrome. She was overweight years ago, and she underwent a partial gastrectomy in 1995. As I mentioned before, she quite recently, in the past 2 years, she underwent an orthopedic surgery for a bilateral knee arthrosis. The medical and the neurological evaluations were normal, completely normal. Her BMI, her body mass index, is 27.6, so she's a little bit over her ideal weight, but nothing particularly to worry. We ran a number of questionnaires. First of all, the Insomnia Severity Index. We will discuss all these questionnaires in detail whenever we discuss the different disorders. But this is a rating scale that evaluates the severity of insomnia. Under medication, lorazepam, she scored a 21 out of 28. 28 is the worst you can have. With the medication, she scored a 21, which is somewhere in between moderate and severe insomnia, that with the medication. Then we ran also she underwent the Beck Depression Inventory and the Hamilton Depression Scale. On both of them, she had a score that were someone around a moderate depression. Also, we interviewed her with the Stop Bank, which is a specific rating scale for telling us the likelihood of respiratory disturbance at night, the Stop Bank, and she scored 3 out of 8. 8 is the maximum likelihood of suffering from sleep apnea, so she scored a 3. And that 3, I must always say this, one of the points was because she was older. The other one was because she was snoring. And the third one was because she was fatigued during the day. So these are very unspecific items, but anyway, she scored at 3 out of 8 points. The Epworth Sleepiness Scale, ESS, she scored at 7 out of 24, which is anything on the Epworth Sleepiness Scale. We will go through that whenever we discuss daytime somnolence, etc. But on the Epworth Sleepiness Scale, anything under 11, 13 at most, is normal. So normal daytime sleepiness. And she also underwent the International Restless Legs Study Group rating scale, where she scored 0 out of 40, which is the maximum. 0 out of 40. She complains of insomnia. Which clinical features of insomnia does she have? First, she has definitely a sleep onset disturbance. She always had a tendency to fall asleep late. Currently, she rarely goes to bed before midnight, and in the absence of any medication, which is rare, she doesn't fall asleep until 1:30 or 2 a.m. So definitely there's a delay in falling asleep. If she takes her medication, she will fall asleep within 30 minutes, with medication, of course. She also has a sleep maintenance disturbance. After the intake of the medication, she will sleep regularly and continuously for 2 hours. Then, after, let's say, 4 a.m., she will start awakening repeatedly for unknown reasons. And at the end, it's very rare for her to be able to sleep at all after 5 a.m. So there is an early morning awakening in most of the nights. During the day, her mood is depressed, and she attributes that to the poor sleep. She's also fatigued, has difficulties concentrating, her work, her cognitive performance is poor, and she's also cranky. She's irritable during the day. She complains also about a heart pounding during the day, and at night also she moves around a lot. There is definitely a hypermotility at night. So, as I said, current treatments, lorazepam, 1 milligram per night for most of the last, I wouldn't say 50 years, but for sure 30 years, for the last 3 decades. She's suffering from hyperglycemia, and she's taking metformin for that, and she's also suffering from hypercholesterolemia, for which she takes atorvastatin. Also, please remember that she underwent a partial gastrectomy, and as a result of that, she has to take vitamin B12, calcium, and vitamin D. In the past, she has been episodically under treatment with oral iron, particularly during the pregnancies. At some point, she was put on quetiapine, which is a neuroleptic, a sedative neuroleptic. And at times, she was also under an antidepressant and SSRI, like escitalopram. But no, not anymore. So far, she's complaining of insomnia. This is the outpatient's clinic. And, well, let's see what would be the diagnosis so far at this point. Let's see what DSM-5 says about the so-called insomnia disorder. In order for a patient to meet criteria for insomnia disorder, the patient has to meet all of the following. Point A, a predominant complaint of dissatisfaction with sleep quantity or quality associated with one of the following: difficulty initiating sleep, difficulty maintaining sleep, early morning awakening, and the sleep difficulty has to be present for at least 3 months. All of them are true. She meets all 4 criteria. So point A is given. In addition, the sleep disturbance has to cause clinical significant distress or impairment in social, occupational, educational, academic, behavioral, or other important areas of functioning. Yes. She has difficulties concentrating. She has difficulties with her memory. Her mood is depressed. There is something not working well during the day, which she attributes to the lack of sleep at night. See, the sleep difficulty occurs despite adequate opportunity for sleep. She has plenty of possibilities to sleep at night. Nobody is preventing her from sleeping at night. If she doesn't sleep more, it's because she cannot. So yes. The insomnia is not better explained by and does not occur exclusively during the course of another sleep-wake disorder. Which other sleep-wake disorder could there be? I don't know of any other. It's insomnia. Insomnia is insomnia. There is no other. There is no reason to think that she's having narcolepsy. So far, there is no reason to think that she's having sleep apnea. Stop band 3 out of 8. There is no reason to think she has no symptoms of RLS, no symptoms of parasomnias. So which other could that be? Yes, point D is also met. The insomnia is not better explained by any other sleep-wake disorder. Point E, coexisting mental disorders and medical conditions do not adequately explain the predominant complaint of insomnia. Here you could say, yes, she's suffering from depression or dysthymia. Could be. However, the depression started to occur over the last 2 years, and she has been suffering from insomnia since age 23. So, since the first pregnancy. So there is no causality. I cannot make the case here that she's suffering from insomnia because she's suffering from depression, because insomnia was there well ahead of depression. If at all, it would be the other way around. F, the insomnia is not attributable to the physiological effects of a substance, like caffeine, like stimulants, like any arousal increasing substance. Everything she's taking is lorazepam. Neither metformin or atorvastatin are drugs that increase excitability or arousal during the day. In addition, DSM-5 establishes 2 different kinds of specifiers. The ones are concomitancies. The insomnia disorder, she definitely meets criteria for insomnia disorder. The question is, what is concomitant to it? With non-sleep disorders, mental comorbidity, including substance use disorders. I wouldn't know of any. At most, you could say there is a concomitancy with depression. Yes. let's not talk about causality, but let's say both are associated and are there at the same time due to probably different causes. Yeah, that could be. The other two possibilities with another medical comorbidity. Which medical comorbidity? Hypercholesterolemia? No. Hyperglycemia? No. With other sleep disorders, which other sleep disorder? There is so far no other sleep disorder. So I would just point to the first possibility. And the other specifiers, according to DSM-5, are time course. If the symptoms last for at least 1 to 3 months, at least 1 month, at most 3 months, then you call it episodic. No, symptoms have been there, the insomnia, for 50 years. So it rather meets more the second possibility, persistent, symptoms lasting more than 3 months. The other one, recurrent, 2 episodes within the space of 1 year, is not the case here. So I would call it persistent. So saying it, putting it all together, so far, according to the clinical diagnosis, what this lady is suffering from is from insomnia disorder with a non-sleep disorder mental comorbidity like depression and with a persistent time course. That would be her diagnosis. If we stopped the story here, there would be therapeutic consequences very clearly. And the therapeutic consequences would be probably, we would start CBT, cognitive behavioral therapy, probably, and we would start changing her medication and treating also her depression. Thanks God, we are not stopping at this point. We normally don't, because whenever somebody has been suffering from that for so long, it's really worth having a closer look at what's really going on objectively. And this is the point at which I want to introduce the point of view of the sleep lab. We could call this the dark side of the moon, if the other one was the non-dark side of the moon. But it's the other way of telling the same story. So let's see what the sleep lab is going to tell us for a case like this. First of all, we had second thoughts, and we decided to perform a multiple suggested immobilization test. What is a multiple suggested immobilization test? It's a test that unfortunately is not performed as frequently as it should. Well, it can be 1 or 2 or 3 different 1-hour tests. Each of them will be 60 minutes. And during each of these tests, we are going to ask the patient to sit down. You can see that in the picture on the left. The patient will sit down with the 2 legs stretched out, not touching each other, not touching anything. Normally we put a pillow, because the legs normally should be not completely extended, but with a pillow below the knees. What we are pretending with this test is to unmask RLS symptoms by means of immobilization. And we will tell the patient, try to stay awake, and also try to remain quiet as you can. We'll discuss this. There will be a special chapter on that, but just so that you understand the meaning of this test. What we will evaluate is the subjective disturbance in the legs, the discomfort in her legs. We will do that by means of a visual analog scale that the technician is going to distribute every 10 minutes. In addition, we will measure the periodic leg movements by means of surface EMG on the anterior tibialis muscle. And what you will see here is something like that. This is a male, a different patient, but he was also a patient that denied suffering from any discomfort in his legs. As you can see, the patient is, you saw the little movement on bilateral. This is what we call a leg jerk, a periodic leg movement. It's a way, by means of immobilization, to unmask a disorder that otherwise would be very likely hidden, wouldn't be diagnosed otherwise, and the patient denies it. Going back to Our Lady, what you can see here is that the result of the EMG testing, we did it twice, at 9 p.m. and at 11 p.m. On the first test, she showed 32 PLMs in an hour while awake. On the second one, 42. Both of them are pathologic. Anything over 15 per hour is normally abnormal. And on the lower side of the slide, what you can see is the visual analog scale. As I mentioned, we run it through the patient every 10 minutes. Over the last 10 minutes, from between 0 and 10, how would you score the degree of discomfort in the lower part of your legs? You can see that on the test that we performed at 9 p.m., she started with a 0, that means no discomfort, but then she got into a 3, a 4, 4, 6, 8, altogether 25. Anything beyond 2 is abnormal. We repeated the test an hour later, and we saw more of the same, even much more severe. She started with a 1, 4, 7, 8, 8, 8, totaling 36. The later we do the test, the more severe it turns out to be, which is one of the characteristics of restless legs. We'll get back to this in a minute. We also performed a polysomnography, and here let's go from the lower part to the upper part. The lower part shows the sleep architecture, and what you can see there is that the upper line is a W. That means that the patient is awake. The x-axis is time throughout the night. And the patient starts at being awake, has some difficulties initially falling asleep. After 20 minutes, fall asleep briefly, gets back to wake. And after, let's say, 1 hour, we see that the patient is trying once and again to fall asleep and is ranging between being awake and stage 2, N2. Is intermittently jumping from awake, sometimes stage 1, and at most stage 2, and then back to wake. You will see that over the main first third of the night, the patient is intermittently running, jumping between being awake and briefly reaching at most stage 2. It's a very, very intermittent awakenings. After, let's say, almost 1 a.m., things stabilize a little bit more, and although she still has awakenings during the night, they are not as frequently as at the beginning. If we go a little bit farther up, we will see the respiratory part of this patient. First of all, the patient has no obstructive apneas. Almost none at all. There are very few. Very, very few. No wonder the stop bank, which normally will evaluate the likelihood of suffering from obstructive sleep apnea, scored a 3, a very lousy 3 out of 8 points, because he has almost no obstructive apneas at all. But if we look on the line that says with a C, we will see that she has many central apneas, particularly at the beginning of the night. And if you look, during the first third of the night, if you look at it, you will see that these central apneas coincide timely with the period of the very unstable sleep, where she's jumping from being awake to stage 2. It's more or less the same part of the night. If you look at respiratory RERA, RERA means respiratory events related arousals. So the arousals assumedly caused by these respiratory events. And you will see that again here, these central apneas, or at the same time as these sleep central apneas, she's suffering from many, many micro arousals. So there are some factors from the one hand, respiratory problems are destabilizing her sleep. If we go up, we will see that she doesn't snore that much. That's really true. But she has a lot of leg movements. You can see that on the line LM, leg movements. She's moving around with her legs all the time during the night. And on the line below, you will see that some of these leg movements are not just leg movements, but even more, furthermore, periodic leg movements. They are occurring in a periodic manner, which would be one of the criteria for restless legs. Knowing that this patient has an abnormal multiple set, shouldn't be a surprise that she's in addition having PLMs at night. And these PLMs are another factor destabilizing sleep and producing central sleep apneas. You can see on this slide, why are we talking about central sleep apnea? We will go through this in detail during the course. There will be a specific lecture for central sleep apnea. But do you see on the 1, 2, 3, 4, 5, 6, the sixth from the bottom, the sixth channel from the bottom where it says flow? This is nasal flow. Do you see that? This is a fragment of, I think, 5 minutes, but there are periods where flow stops. That means the patient stops breathing. So, and the patient stops breathing for at least, that could be easily 30, 40 seconds. In each time, the patient meets criteria for an apnea. Well, what does she increase her thoracic or her abdominal effort? Why would she do that? Normally, whenever there is an obstruction in the upper airways, the rest of the body, the thoracic and in addition also the abdominal muscles, the diaphragmatic effort increases, trying to overcome the obstacle, trying to overcome the obstruction. This is what normally would happen in obstructive apneas, but in this case, nothing happens. There is stillstand. There is no increased respiratory effort because the cause of the apneas is central. It's, in other words, we'll discuss it in a minute. The problem is that the central drive for driving the respiration located in the brain is not giving orders to resume breathing. This is what a central apnea will look like. In addition, she's having leg movements. You can see that on the channel titled right leg. And she's having also some minor snoring, but also micro arousals on the EEG. So we see 3 elements coinciding in time at the same time. One is the central apneas, the second one is the sleep fragmentation, and we see at the same time the leg movements. Let's change gears just for a second. One of the things that this patient told us was that she had always difficulties falling asleep. This suggests, and then all that happened because well before she was overweight, all that happened before she got any depression or anything like that. Maybe there is a problem with the circadian clock. And what we did in order to check the functioning of the circadian clock was to do a nocturnal salivary melatonin test. Normally you do this test right before bedtime. What we normally do, we start at 9 p.m., in some cases at 8 p.m., and keep the patient in a dark room under total darkness, sitting quiet and not doing a lot more for 4 hours until midnight, or in this case until 1 a.m. And every hour we sample some amount of saliva and send it to measure, to evaluate for the concentration, for salivary concentration of melatonin. When the circadian system, when the circadian clock starts functioning at night, one of the first order it gives is to the pineal gland. And the pineal gland, which is a factory producing melatonin, will release melatonin in the body fluids, mainly in serum, in plasma, but also in saliva. What we do here is we measure the time point at which the patient reaches a specific concentration, and this is the one referred to as 4 picograms per milliliter. This is an international standard convention. At the time point at which the patient reaches that salivary concentration is what we call the dim light melatonin onset, the DELMO. And this is a marker of initiation of the function of the circadian clock. This is the so-called DELMO. In this case, it's clearly late. It should be well before 10, around 10 p.m. normally, for her age. It's somewhere like at around 12:30 at night. That's clearly very late. So no wonder that this patient, the entire machinery, preparing the brain to initiate sleep starts late. And no wonder the patient falls asleep anyway late. Just to show you what is RLS, what are the diagnostic criteria for RLS. We'll discuss RLS in detail at some point during the course. But patients experience normally an urge to move the legs. This urge to move the legs begins or worsens during periods of rest, of inactivity, such as laying down or sitting. The urge to move the legs are partially or totally relieved by movement, and the urge to move the legs are worse at night and in the morning. Yes to all 4 of them. The 5th essential criterion is that there shouldn't be any other explanation for this urge to move the legs, either medical, pharmacological, behavioral, etc. So she meets these criteria. We have seen this live. We have seen this in real time during the multiple suggested immobilization test. In addition, she has PLMs. We saw that during the polysomnography. Patients normally have a positive response to dopaminergic drugs. We didn't have the chance so far to test that. Also, patients frequently have a positive family history among first-degree relatives. We have not, at this point, we have not asked the patient about that. But these patients normally have a history of iron deficiency. I can tell you that for sure, yes, of course, she does, because she was treated with iron during her pregnancies. Why would they do that? The most likely thing is that she might have run into some degree of iron deficiency while expecting the baby. And a lack of expected daytime sleepiness. Well, I think she scored 7 out of 24 in the Epworth Sleepiness Scale. So she meets criteria for RLS. However, when we run the rating scale, she scored at 0 out of 40. Why? Okay, I'll get to this point in a minute. The blood test. We also ran a blood test. Her blood glucose is normal, but she's under treatment. She's under metformin. Also, her cholesterol, her serum cholesterol, her cholesterolemia is a little bit increased, 210, under atorvastatin. We also looked at iron measurements. Hemoglobin is at 13. It's a little bit on the lower end. Serum iron is okay, 166. The transferrin saturation is low. It's really on the lower margin, 19%. That depends on the laboratory. Our laboratory, in this case, puts the threshold at 18, but she's very close to the lower margin. And remember, this is plasma iron. In addition, ferritin is at 32, but it's within the normal range, but close to the lower end of the normal range. But when we talk about restless legs, the important thing is not so much to see how is peripheric iron, but to see how is brain iron. And one of the techniques that we have been using, that was a development of Dr. Garcia Malo sitting on my right, was to try to measure brain iron by means of transcranial sonography. It's a completely 100% harmless technique. And what we do is we get a picture of the midbrain and focus specifically on the echogenicity of the substantia nigra. The substantia nigra is a structure in the midbrain that is the main CNS iron store. We will focus at it and try to see what the degree of echogenicity, and you will see that in the picture by you see the perimeter of it. It's signaled on the right hand side of the picture. We measure the surface, and that provides a number, and that number is a very reliable marker of the content of brain iron. In this case, the echogenicity index, the substantia nigra echogenicity index, the so-called SNI, is 0.08. Anything below 0.20 is low. In this case, for this lady, while peripheral serum iron is, in general terms, marginally low, we can definitely also say that her brain iron is severely low. And this is really what is causing, at the end, restless legs. The question here is, as I was saying before, is why did she scored 0 on the IRLS scale? Well, there's a little trick in that. This rating scale, the IRLS rating scale, is supposed to be administered to patients that have RLS, that suffer from RLS, because the questions will go in the following way. Over the last week, for example, how much has your sleep been impaired as a result of your restless legs? As a result of your restless legs. If the patient believes that she doesn't have RLS, she will answer 0. I haven't slept at all, or I have slept very little, but not because of the RLS. I don't have RLS. And most of the questions are because of the RLS. It's assuming a priori that you have RLS. And if you don't explain this well to the patient, if you don't explain to the patient that really there is a hypermotility at night, she will indeed give you a so-called false negative. In addition, we run a 7-day RLS agenda, and what you can see here is that once you explain her what she has, she scores on the IRLS scale, and she scores clearly on the IRLS agenda. So the question is here, where do we stand right now? We have done a clinical diagnosis, and we have done also a laboratory diagnosis. According to the clinical diagnosis, as I said before, she has insomnia disorder. According to the laboratory diagnosis, she has insomnia. Yes, she slept very little also during the PSG study. She has a delayed sleep phase syndrome, a circadian rhythm disorder that was clearly shown by the melatonin, by the DELMO testing, dim light melatonin onset test, and she has RLS, and she has sleep onset central apneas. And these are the two sides of reality. A few words about central apneas. Normally, there are 3 levels of respiratory control. When we are awake, there is a behavioral level of respiratory control. We are all awake, but in contrast to you, I'm exerting an active behavior of speaking that has to have any impact on my respiratory drive. So the degree, the behavior you are having at each time point will increase or lower your respiratory drive. Not to say I'm talking right now, but if you were doing exercise, so your respiratory drive would be accordingly higher. But just the fact of being awake increases the stimulates the so-called wakefulness drive. So what happens when you fall asleep, when you initiate sleep? The minute you initiate sleep, you are in the hands, first of all, both the behavioral drive and the wakefulness drive are neutralized. They are, they stopped. And your respiration, your ventilatory drive depends basically on chemoreceptors. There are 2 types of chemoreceptors. First, the central ones, which are sensitive to pH on the CSF. They are located in the brainstem, ventrolateral medulla oblongata. In addition, there are the peripheral chemoreceptors, which one of them is located in the aortic body and the other one in the carotid body. The one located on the aortic body is sensitive to changes in PO2 and particularly changes in PCO2. While the other one, the one on the carotid body, is sensitive to PO2, PCO2, and pH. But keep the following thing in mind. The one really running your ventilatory, the chemoreceptor really running your ventilatory drive during the night is getting mainly information from PCO2. And this is an important important slide to understand, because it shows on the x-axis the PCO2 that is necessary to trigger your ventilatory drive. If you look, anything under 40 won't trigger the ventilatory drive, but as soon as you reach the 40 millimeters of PCO2 pressure, then your ventilatory drive will start shooting on. You see the curve, so it will increase immensely. However, this is the threshold that starts shooting while you are awake. What happens if you are asleep? This is what happens. Let's look at N2. If you see there the threshold for the initiation of the increase in ventilatory drive, when any human person is in N2, is a little bit over the one we use for awake. It's approximately at 45 millimeters. So what happens when somebody falls asleep? There is a territory between 40 and 45 millimeters that is, I call it the Wild West, nobody's land, because nobody is going to take care of your minute ventilation until you reach the 45 So in other words, if while being awake, you are still under control of several behavioral in the wakefulness drive and also the PCO2, as soon as you fall asleep and you get into N1 and even more you get into N2, the threshold won't be, the PCO2 won't be sufficient to stimulate respiration. And this will lead to a momentary central apnea, to a momentary transitory hypoventilation. The hypoventilation will lead to an increase of the PCO2, and the PCO2 will be catched by the chemoreceptors, and then when you reach the 45 millimeters, then your brainstem will start shutting on again. This is the physiological basis for this kind of apneas, and you can see that here, well, I mentioned this already here. Initially, while awake, the patient is at 40, and when sleep is initiated, there is a period on which you are in nobody's land until you reach the 45 millimeters of mercury, and then you will again reach a eucapnic level. During that period, the patient will have central apneas. As a last slide, one of the last two slides, just summarizing where we stand here. Well, we know that the patient has a delayed sleep phase syndrome, and that by itself leads to sleep onset insomnia. We also know that the patient has a brain iron deficit. This will lead to RLS. This will lead to PLMs, periodic leg movements, and the RLS will further increase or add to the sleep onset insomnia, and it will also contribute to the sleep maintenance insomnia. On its side, the PLMs will fragment the sleep and will also contribute to the sleep onset insomnia. So there are several factors affecting each other, retroalimenting, retro-nourishing each other. The fragmented sleep, as we showed before, lead to transitional sleep onset central apneas. And the sleep onset central apneas further make the sleep onset insomnia more difficult. We shouldn't forget, we got into the medical field completely, but this patient is also having a dysthymia. And the dysthymia also leads to both a sleep onset insomnia and a sleep maintenance insomnia. In addition to that, she has been using benzodiazepines for years. That further makes the sleep maintenance insomnia, particularly the sleep maintenance insomnia, chronic. So what can we do? These are just a couple of suggestions. If there is a brain iron deficiency, we could give iron. We could also give oral iron, but oral iron is probably going to take too long. The most likely thing, if we want really to get rid of the brain iron deficiency will be administering IV iron. That's one of the possibilities. We could also treat the RLS and the PLMs with pregabalin. Why not with the dopamine agonist, pramipexole? Well, okay, we could also do that, but pramipexole doesn't have any stabilizing effects on sleep, while pregabalin further consolidates sleep. I would rather go for pregabalin, but you could do it also in a different way. Another way would be to make a treatment trial with zolpidem, particularly because this patient is having problems at sleep onset, because she's having a lot of instability with the central apneas and with the many PLMs and the microarousals at the beginning. Well, if we just push the patient with zolpidem, which is a short-acting benzodiazepine agonist, it would be a way of getting over the bridge quickly. Let's push her through the river. It's a way of handling it. It's another possibility. In addition, other possibilities would be to treat the transitional central apneas with oxygen, or maybe with respiratory stimulants like progesterone or acetazolamide. I put a question mark on both of them because there is no consensus on the efficacy of these treatments for central apnea. The delayed sleep phase syndrome could be treated with melatonin at night or light therapy in the morning. These are two possibilities. And the dysthymia could be treated with an SSRI, probably something like bupropion, because bupropion acts on two ways. It has two different mechanisms. It will inhibit the reuptake of serotonin, and it will further inhibit the reuptake of dopamine. And by doing the latter, the later, we will further add to the therapeutic effects on RLS. So these are just possibilities to handle the picture. But the point I wanted to make mainly here is, and for the chronic use of benzodiazepines, well, there we could really well do the CBT, cognitive behavioral therapy. We'll have a lesson on CBT, how to do a cognitive behavioral therapy. And we'll have one of the world leaders of CBT, which is Colin Espy. And we can also do a gradual tapering down of the benzodiazepines in order to avoid a rebound. These are the possibilities that we have here. What we did finally was to give a ferric carboxymaltose, which is a way of giving IV iron, 1,500 milligrams IV in 2 different doses. We also administered pregabalin. We treated the dysthymia with 150 milligrams of bupropion, and we administered first melatonin at bedtime. And at the same time, she entered a program of cognitive behavioral therapy, and also we performed a gradual tapering down of lorazepam. So, taking together the point I'm trying to make, and that we will try to make over the entire master. Clinical sleep medicine has many phases. There are many elements playing a role. Normally, we need to interact with other colleagues from other specialties all the time. We need their advice. We need to know what the other colleagues, what the respiratory colleagues are doing. We need to know what the neurologist is doing. Although we might not be mastering it, but we know to be talking to each other all the time, because sleep medicine in some way is a kind of internal medicine of the night. I didn't discuss here the behavioral aspects, because otherwise I would have bored you for 2 hours longer. But there is also an element of behavior. There's an element of psychiatry, and this also plays and interacts with more medical aspects. And this is what really makes this field fascinating. Having said that, I don't know whether there is time for any questions. I would be happy to answer them. But if not, the main message is that we have to look at things from several perspectives at the same time. Thank you very much.
Thank you. Thank you very much, Dr. García Borreguero, for this really interesting talk and amazing. And I think it's a very clear clinical case of being sleep medicine as a multidisciplinary science in a way. So I think it was a great talk. Yeah, we have time, I think, for questions, and we have two sort of questions from the audience. There are some of technical questions which I can answer, and then I can give you the floor, because there are sort of more like scientific questions about your talk. So
Sure.
the first question we have is technical. Is the degree recognized in a matter of doing a PhD after finishing this degree? Well, I should say no, because this is one has to have a degree and then go to a master and then go to the PhD, but no, this master degree, not just this master degree, you got the number of ESTS necessary to go to a PhD. So the second question is, it is possible to do some of the courses aside from the internship in campus? No, I'm afraid no is the answer, because this master, as we have all said, is fully taught online, so 100% online. And the third question is, does this master include internships? Well, this master, as we said, has 48 hours of clinical cases, but all of them is running online. But you have the possibility of having more face-to-face learning to prepare to the exam, doing practical training and internships, but this has additional cost, as Dr. Cano has already said before.
But may I just say a word on that, on the last thing? I mean, it's going to work in the following way. Sorry. Sorry. It's going to work in the following way. I mean, first of all, you will get during the master's degree a certain amount of practical exposure. But after that, or maybe before that if you want, you can also do clinics with us. And it will work in the following way. I mean, there will be a specific schedule for that. And you will be assigned to, let's say, Monday and Tuesdays and Wednesdays, and between that and that time to be online. The patient will come to the office, to the clinic, and you will be on the computer, on the video. See, exactly the same way as if you were sitting next to us. You will be listening to the patient. You will be, if the person doesn't speak Spanish, we will translate. We'll have to do some work of translation, but if the doctor is Spanish speaking, there won't be such a problem. I mean, but we can arrange it in any way. And we'll have a dialogue between the patient, the doctor, the trainee, and ourselves. This is, we can really, you won't feel a big difference between sitting in your office in your country and sitting next to us. We will also be able to review polysomnographies. You will be also able to review the different tests that will be coming up. You will participate with us in the decision, in the diagnostic decision-making process. And that will develop your exposure, your way of thinking in terms of sleep medicine, in terms of choosing different treatments, in terms of managing therapeutic problems, in the same way as if you were sitting with us in Madrid. Whoever wants to come to Madrid is also happy to come, but we can do it in that way. Those of you that want to take the ESRS exam, one of the requirements of the ESRS exam is you are supposed to be able to certify that you have been working at a sleep clinic, at a recognized sleep clinic for a period of 1 year. Depends, I mean, if you have been already working somewhere, we will be able to provide you with the remaining time, with the time you still need, up to 1 year. And if somebody needs the entire year, we also will be happy to do that.
Okay. Thank you very much, Diego. Now we have 3 questions from the audience, and I shall ask you if you prefer.
Yeah.
I think it's for
Okay,
Dr.
that's fine.
Garcia
Yeah,
Borrero.
okay.
The 3 at the same time, or one after the other?
One
Or
after the
we'll
other.
do one after the other.
That's fine. Yeah.
Okay. Well, the first question is, how do we treat insomnia with RLS? That's the first question.
Insomnia together with RLS.
Yeah.
Okay, let's treat the RLS first, I would say. Let's treat the RLS first. Sorry, I'm not good at this. During the course, I will get used to that, taking it off and putting it on again. Now, okay, let's treat the RLS first. What is the cause of RLS? Is brain iron deficiency the cause of the RLS? Let's tackle on that. The other thing is, let's treat the RLS with a drug that also helps us to stabilize sleep. And what we do there is, that was the reason why I wrote on the slide, pregabalin or gabapentin are drugs that, on the one hand, they diminish the PLMs, they also diminish the sensory abnormalities of RLS, but they also consolidate sleep at the same time. I would make a trial with that. I would tell the patient, let's do a 2-3 week trial and see what happens to your insomnia. There are several possibilities. That still, the insomnia is still there, etc., etc. The RLS is gone, but insomnia is still bothering at night. No? And then I would consider starting a cognitive behavioral therapeutic program. So I would treat the more organic, the more medical condition first for a brief period of time, and on a second step, I would go for the insomnia. In some cases, but this is the last resource, I would consider adding a small dose of a benzodiazepine, but this is truly the last resource.
Okay, thank you very much. Well, these 2 questions are very related, so I can make them together. Well, you know. And is it necessary to treat RLS with iron? If it is so, which is better, oral treatment or intravenous treatment?
Mm-hmm.
And that's it.
RLS should be treated with iron if either serum iron is low, or if brain iron is low. If either of the 2 is low, then yes. If there is no reason, I mean, if neither serum iron proves to be low, or brain iron proves to be low, if neither of the 2 proves to be low, then you can still do a treatment trial, but it's going to be, the likelihood of getting a response is going to be much, much lower. The second thing is, what is better, oral or IV iron? Well, there are guidelines on that. If we stay on the guidelines, the main problem, I'm a little bit heterodoxical with the guidelines, because there have been new developments since these guidelines were published 3 years ago. And so the new developments changed the way I see these guidelines. I was a co-author on the guidelines, but I'm one of the ones that is starting to have second thoughts on that. I would base, let's put it in the following way. If the serum iron levels, I'm talking here about ferritin or a transferrin saturation, the TSAT, if any of the 2 are low, you can definitely start with oral iron. You should make sure that the patient is not secreting hepcidin, because the hepcidin is going to block the gastrointestinal absorption. And then if the patient is developing too much hepcidin, it will block so you can give as much iron as you want. It won't be absorbed. However, if serum iron, any of the two, either ferritin or the TSAT, are normal or even high, I would look more into the brain iron. And if the brain iron is low, I would go more for IV iron. That's the way we approach the thing. I can also give you numbers, but the basic thing is to be able to have the capacity to measure brain iron. Why IV iron? Because IV iron will bypass the first absorption obstacle at the gastrointestinal tract. So what we need ultimately, we'll discuss this whenever we discuss RLS, we need to increase serum ferritin to up to 300, 400 nanogram per milliliter in a transitory way, so that this increase in serum iron is absorbed into the brain. And even having done that, we will need to wait for 3 or 4 months normally. So in other words, just to summarize, if serum iron is very low, you can go easily with, you can make a trial first with oral iron, but if it's in the medium or it's even high, then I would go first with IV iron.
Thank you.
There are other factors that also need to be considered here. Just to say it, because I stated the whole thing just in terms of efficacy. Let's make a statement on toxicity. Oral iron is frequently very badly tolerated. Patients get a very bad stomach normally, or constipation. If the patient has difficulties with the intake of oral iron, then I will go definitely directly into IV iron. Yeah. Sorry.
Thank you. No, it was a good point. So it's very good to justify. So we have another question from the audience that was, will the master's degree be held annually? Yes, we hope so. That's our perspective. That is going to be many editions, we hope, don't we? So I don't know if there is more questions from the audience, because it's nearly just, we are getting to the end, or you have?
I want to make a final point. Well, I don't know whether final, but at least final for me. You can take, I don't know whether this is clear to everyone. Every lecture will be given in 2 languages. It will be given in English, and the same lecture will be given in Spanish. It's up to you. You can take it just in English, if this is the language you normally speak. You can also take it in Spanish, or you can take it in both and improve your Spanish. I mean, but it's up to you. We'll make it depending really on your choice. The webinars will be in English. The slides will be mostly in English as well. The reason for that is because the exam will be mainly in English. Mm-hmm.
Okay, then, so I think we're getting to the end, so I just hope that all you, the audience, have gained a whole perspective about the International Online Master in Sleep Medicine, offered by the Sleep Research Institute in collaboration with the Universidad Europea de Madrid. I hope you find this project as challenging as we do, and you find it as interesting as we do. But in any case, do not hesitate to ask us any questions you have. And just to finish, I want to thank both the attendants and the speakers, Dr. García Borreguero, Dr. Celia García, and Dr. Irene. I want to grade your participation. It was really nice to have you here with me, and thank you very much everywhere in the audience. Thank you.
Thanks, Frederic.